Hi. Hi.
Hi.
Hi.
Hi, hello. How are you?
Hi, hello. I'm good.
Alrighty. So through technical error, not era, like the era of technology, error, like mistake. I'm going to do a quick summary of what we discussed last week. There you are. I think I can't. My hair is a mess, so you're brave.
Oh, mine's not that great either. Ugh.
I'll just start the recording. Oh, it is recording. Yay. So I'm just going to go over a couple of things that I mentioned last week. One of the things I want to mention is next week you have an exam, I believe next week in theory, and then the following week in pharmacology, October 1st. And so here we are just waltzing through 2021 at a brisk polka, perhaps. So unfortunately, it didn't record last week. So I'm going to run through a couple of items that I discussed last week. Certainly, they will be beneficial as we enter the exam in a couple of weeks. So we're just going to go over a few things that we talked about. We talked about toxic effect of drugs. We talked about the nursing process, which is very, very instrumental in your success. And certainly dosage cal. Chapter 5 deals with dosage calculation, so please review that. I know that you're going through it in other areas of this semester as well. So if you have any questions about dosage cal, please reach out. Most of the questions in the dosage exam or in the exam content on dosage are very basic, volume equivalence as far as metric, simple conversions. Dr. Starkovich, do you have anything to add about that as far as um, pharmacology 1 and dosage cal? Pretty basic.
Yeah. No, I do not. Make sure you know what tenths and hundredths are.
And also make sure when you are dosing children, you realize that they are typically dosed by weight, and that weight is always in kilograms. So you'll have to convert to answer the questions properly, certainly effectively and safely, especially when you're at the bedside. You will use the conversion. So remember or review how to do that. So one thing I'll start out with is who is responsible for explaining the toxic effects of the drugs to the patients? Absolutely who? Always, always, always the nurse. The nurse is the person that assesses. Absolutely, Sabina, thank you. The nurse is the person that takes the medication history. Certainly, one of the reasons why we take a medication history, among other things, is to find out if some of their drugs can actually interact with each other. And that's always a problem. And certainly, we want to determine if they have any allergies. Allergies, of course, are drug allergies, is when your body forms antibodies to a specific drug protein. And then the next time you receive that particular drug, you have an immune response. Um, and so when it's exposed to the drug or the antigen, that's when you develop an immune response. Certainly, if it becomes life-threatening, like you can't catch your breath, or you feel short of breath, or your face starts to swell, or your tongue starts to swell, that's a condition known as anaphylaxis. And some of the drugs that we'll talk about, particularly ACE inhibitors, they can they can cause something called an ACE inhibitor cough. And most of the time when the patient begins this medication and they start to have this cough, most of the time, predominantly, it's discontinued and another drug is initiated, simply because this ACE inhibitor cough can certainly be the precursor to angioedema and or Stevens-Johnson syndrome, which we'll talk about both those things at length next semester in Pharm 2. Some drugs are teratogenic. What does that mean? Does anybody know what does teratogenicity mean? Affects the fetus. Absolutely. It's very, it's uh, affects women of childbearing years who are certainly pregnant. And certainly you don't prescribe those drugs, especially like an ACE inhibitor. It is not recommended for women of childbearing years, because sometimes, as in my case, a couple of times I didn't even realize I was pregnant until, of course, I began to feel tragically nauseated. So we always have to be aware of those things. We have to be aware of side effects that may even impair the kidney or the liver. Certainly a lot of the drugs are very unfriendly to the kidney and the liver. Most of them we'll talk about next semester. One of the ones we'll talk about this semester is the aminoglycosides. Certainly those that particular class carries some precautions and some different assessments. And speaking of assessment, the nurse says always start with assessment. Even if you walk into your patient's room, you kind of take a windshield view of their situation. If they're red and seem like they can't catch their breath, certainly we might want to do something before we begin to assess them or give them a medication or something. On over-the-counter medications, we talked about this last week, but we always consult a drug guide for anything, usually a drug guide within the past 3 to 5 years, erring on the 3 side. And most of the time your Pyxis machine or your med administration machine in the facility will have an up-to-date, very up-to-date service point or access point on the computer software itself. And you always have to check, as with over-the-counters. A lot of the over-the-counter will not only interfere with prescription drugs, but they'll also mask signs and symptoms of toxicity of the other drugs. We also talked about black box warnings. Some, especially antidepressants that we'll talk about, can carry black box warnings for suicide ideations in children and adolescents, and we always look for that as well. My special needs daughter, takes a drug with a black box warning for suicide. She's 25, however, and she talks about laying in the street. And on other news, she's deaf and blind and certainly couldn't get to the street. However, she's certainly watched and monitored very closely for things like that. Let's see. We talked about the nursing process. Know the steps of the nursing process. Obviously, number one of the first step is assess. You always assess, especially when you start a new medication. You look for adverse effects. You also assess after you give a pain medicine. And you always follow up to see if the pain's relieved or if the pain has increased, gotten worse, as actually may have gotten worse as well. Let's see, we talk about other drug reactions. Some of the drugs we'll talk about a few this semester, but a whole lot next semester. Is some drug reactions can have extrapyramidal side effects. And what that means is that these drugs affect the nervous system, which we'll talk about a little bit today, and it causes a nervous tics and jerking of the neck and sometimes face or parts of the face. Sometimes actions can be more system specific, as in the case of some antiepileptics, or certainly they can be systemic, as in the case of some antibiotics. Tetracycline, as a matter of fact, is one of those drugs that's very system specific. It has to do with the dentation of the secondary. Certainly that's something to exercise caution if your patient's a small child and they've been prescribed this medication. Certainly double check on the dose with the provider, and to try to assure the minimum possible dose, or perhaps even another medication can be given. Primary infections are usually those that kind of unfold. Secondary infection is something that's caused by another infection that just never got completely taken care of. And certainly you can get a secondary infection if the medication you give for the primary infection wasn't adequate enough to deal with either the bacterial or the bacterial load or the infection per se. Certainly toxic. There are a lot of toxic effects of drugs. I mentioned that children are dosed by weight. Certainly it's something that you will sometimes calculate out to the hundredths instead of just the tenths. Always consult a drug guide and get a medical history. We talked about that at length last week as well. And as a reminder, we go through the 5 steps of the nursing process: ADPIE, ADPIE, assessment, diagnosis, plan, and then evaluate. Always evaluate. And certainly, as we give medications, there are a lot of steps in the assessment of the patient. Certainly, allergies is among them. Certainly, if your patient is having trouble with memory or some sort of a cognitive decline, you can do drug teaching with their significant other or somebody that will be checking on them. There's certain things you can do. Obviously, provide pill boxes, days of the week, AM, PM, anything that you can do for memory prompts, of course, because you'll be responsible for all of the drug teaching. And when you teach a patient about their drugs, always ask them to repeat the information you've told them, because if your patient is like most members of my family, they just can't wait to get out of the hospital, and they'll just nod at anything. And so sometimes it's very difficult to know if they've gotten the information or not. So that's kind of how it rolled last week. If you weren't able to come, if you weren't able to be there, that's kind of an overview of the fun we had last week. And certainly if you were able to attend, then that's certainly even a better second attempt, or second chance, I suppose, at a little bit of an exam review as well. So does anybody have any questions about all of the stuff I just rattled off in probably 11, no, not 11, maybe 11 minutes? Crickets, crickets. Dr. Starkovich, is there anything you might add? Oh, good. Thanks, Michelle. All righty, so I'm going to give a...
Sorry, we talked about secondary usages too. I didn't hear you go over that, but that doesn't sound right. Secondary usage, is that the right word? But a secondary, whatever, is when the drug, yeah, like off-label use, yeah. It's like when the drug is meant for something, for our primary issue, but it's approved to be used for something else. We talked about Wellbutrin and Viagra for that, like Wellbutrin for smoking cessation versus an antidepressant, and antidepressants for pain control as well. So that's all.
And you'll also find out next semester, like in the case of cancer and cancer treatment, antidepressants are used as a somatic form of pain control. There are a lot of somatic pain is triggered by organs that are enlarged. There's a lining or a covering over your major organs that when stretched, it causes extreme pain. And some of the somatic pain can certainly be relieved by antidepressants. And certainly they carry the dual function of also obviously dealing with the stress and the anxiety, angst, if I may use that word, of a cancer diagnosis. So yeah, and off-labels or uses are certainly gabapentin it can be used for seizures. We'll talk about gabapentin next semester, but it can be used for restless leg. But if you give it at night, it also has a very sedating effect. So an off-label use would be, and it also, interestingly enough, has a calming effect. So if your patient is a little aggressive and they have restless leg, well, then it's a twofer with a gabapentin, or actually a threefer, because if you give it at night, then it also causes or has the tendency to bring on a sedating effect. And they say also that there's a drug, Tagamet, which is a GI drug. If we've had patients in the nursing home that have become sexually aggressive, whether it's self or others, and sometimes the Tagamet has been known to blunt the libido. So there's all sorts of off-label uses for that stuff as well. The only problem, like with anything,
Benadryl as a sleeping pill too is off-label use. It's not approved as a sleeping pill, but you can still use it that way. Off-label usage.
Yeah, off-label.
Go ahead.
Yes, it is. It is frowned upon. You can't when you enter an order into the computer system, you can't say Benadryl for sleep unless you have hypnotics. All need consents. You can't say Tagamet to curb sexual aggression. You can't say those things because they're not, an insurance company won't pay for it. So you have to certainly reap the benefits under the specific prescriptive ideation of the drug.
Right. And if it's a secondary usage instead of a primary, those are typically approved by whatever governing agency. So, Wellbutrin's approved as a smoking cessation medication. So it wouldn't necessarily be off-label use because the FDA has said there's enough research that says that this is effective in that avenue. Hopefully that didn't confuse everybody.
And you can also taper that as well. If you're using it as a secondary, it can be tapered. You can do X number of milligrams, and then continue on a weekly taper as well.
Yes, there's 3: primary, secondary, and off-label. Off-label is not approved. There's no research really to say that it's safe to use the medication in that manner, but a lot of people will. There's some drug that they use for itching as well. It's not for itching, but that's one of the side effects is that it helps decrease itching. Oh my gosh, sorry, my brain is dead again, guys. It helps. What would be decreasing of itching, Dr. K? What's your medical term for that? I don't know. Helps with
Anti-itch?
itching. Yeah, it's like an anti-itch. Yeah. I can't think of what drug
Itch no
that
more.
is. Yeah, it's
Itch
no
no
more, but
more.
it's really good. It's really good when people are experiencing side effect of anesthesia, but it's not for itch.
Yeah, Kristen, that's a good point. It's usually an antihistamine by nature, by a chemical compound, and so yeah, antihistamine. Certainly, the histaminic responds to anything. What is for itching anyway? Let me see what drug for itching.
Well, one of the
Now you
drugs
have
that
me.
we talked about in
Now you,
class has an anti-itch effectiveness. That's not what it's for, but it is used as that at times. I can't. I want to say it's Sotalol, but I feel like that is completely wrong.
but for some reason, Prozac or SSRIs um, can do it as well. Interestingly enough, but certainly um, maybe that's an itch based on some sort of anxiety, perhaps. Anywho, speaking of anxiety and that sort of thing, um, do we have any questions about what we just talked about? I mean, I'm not anxious or anything, but does anybody have any things to add or subtract or? Alrighty. So we're going to talk about anxiolytics and hypnotics tonight, and also antidepressant agents. Just kind of a precursor to our convo. Um, the functions, of course, the neurons make up the functional part of the nervous system. They're composed of course, a dendrite, an axon. They're the functional units, okay? And what they do is they're the information pathway. And they have action potential, of course, a sudden change from a negative to a positive. It's all about electronics, our systems are, certainly our nervous system. And so it allows the ion channel to open up and positive sodium ions to flow into the cells. That's kind of just the down and dirty of it, for sure. The hindbrain, of course, being the most primitive part of the brain, it controls all the basic autonomic functions like breathing, etc. You can hold your breath, but your body, your hindbrain won't let you do it for long because at some point you're just going to take another breath. Unless, of course, you're underwater, and then that's not going to be very beneficial to you at all. We have a reticular activating system, which, of course, is located in the hindbrain as well. And it's kind of our awareness, which regulates arousal. And then you have the cerebellum, which is the motor part, and it's found behind or the back. The midbrain has the hypothalamus and the thalamus and the limbic system. And certainly the limbic system is our emotion center. And the other parts of the hypothalamus and the thalamus, they basically coordinate external responses to our environment. Of course, we have a right and left hemisphere, which differentiates between our thinking and our learning and our creative side. And interestingly enough, Albert Einstein, there's a sulcus that goes down the middle of your head. It's like separates your right from your left brain. And very creative people like Albert Einstein had a very narrow sulcus, which meant that in anatomical sense, that his right and his left brain were in much contact. So he could actually think in 5 dimensions, which is why he certainly gave us many theories and postulates. Michelangelo was another person who could do that. He could look at a piece of rock and see David inside and just chip away what wasn't David. So I know that I didn't actually intend to do a little art history, maybe science review, but all that was for free. There'll be no charge for that, certainly. And I can promise you none of that will be on your exam. I don't know. Maybe we could, Dr. Starkovich, we could put a little question, like a bonus question on their exam.
Yeah, change it up a little.
Change it up a little. Yes, right. Why did Michelangelo? How could he see David in the rock? Well, that's because his right and his left brain were besties. Maybe we could come up. Yeah, extra credit. There you go. So, hey, you know what? We just might do that, kind of as a bonus to all 27 of you who are here and those who may even listen to it. So here we go.
It. Yeah, I like it. That's nice.
I do too. And you have to be able to go to a gathering, a party, or whatever, and talk about more than just pharmacology. So that's like a free social introduction. So anyway, oh, there you go. So let's talk about hypnotics, anxiolytics and hypnotics. What is an anxiolytic? What does an anxiolytic do? Well, funny you should ask. An anxiolytic, such as a benzodiazepine, depress the central nervous system to diminish feelings of anxiety. Now, a lot of the anxiolytics, what are some examples of anxiolytics? Does anybody know? What are some examples of anxiolytics? Xanax, Ativan as well. Ativan, clonazepam, Xanax, Cirex. Okay, anxiolytics take the edge off of anxiety. They usually work pretty rapidly, but they only work on anxiety, and they are not effective in dementia at all. You'll see a lot of people in a nursing home being given in Ativan, but unfortunately, the benzodiazepines work in anxiety, and they also work in status epilepticus, which we'll certainly talk about next semester as well. So then you have anxiolytics, and then you have sedatives, and they're also while anxiolytics depress the CNS to diminish the feelings of anxiety. CNS depressants such as sedatives block the awareness and the reaction or the response to the environmental stimulus. They produce drowsiness or hypnosis, as the name implies, and they certainly inhibit neuronal response or arousal. In specific, they react with GABA to depress the CNS. They can cause lethargy, drowsiness, and certainly overdose. All of these medications are metabolized in the liver. So certainly if your patient has liver issues, they may need decreased dosages, diminished dosages. And if your patient is on any of these drugs, you never, ever, never go cold turkey on them. They will not like that, and they will respond up to and including sudden death, which is certainly a position you don't want to find yourself in, for sure. So there are a lot of nursing implications that go along considerations for patients receiving benzos. So you don't give them arterially, because they cause serious arterial spasms, and certainly if trapped in the tissues can cause gangrene. You have to monitor sites very much for tissue necrosis from benzodiazepines. You don't mix them in any solution with any other drugs, because the potential for drug interaction in this class of medications is very, very, very extremely high. Certainly, parenteral forms are the best. Oral is the best, and certainly avoid, if possible. Some Ativan is given in extreme psychotic cases. It's called the Holy Trinity. I think it's Ativan, Benadryl, and Haldol. And that is something that is not recommended in the elderly, and certainly only used judiciously and sparingly in very young schizophrenic manic patients. The state of Texas actually, the CDC and Health and Human Services said that as soon as your patient is placed on a narcotic, analgesic, and or a hypnotic, you must immediately make plans to do timed dose reductions, because these drugs are certainly detrimental in the for long-term use, and place patients, particularly the elderly, at a risk, a health risk. Certainly, they can fall, break something. People that operate heavy machinery certainly shouldn't be on them for long periods of time. And always remember to taper gradually after long-term therapy, particularly if your patient has epilepsy or seizure disorders as well. Acute withdrawal could precipitate seizures in these patients, even if they don't have seizures. Because remember, these drugs inhibit the central nervous system. So if your patient is on these drugs and you withdraw it, their central nervous system could become very excited, very excitable, and any little trigger could set them off into status epilepticus, which is often fatal. Is this AKA 5210? Jasper, what do you mean by that?
I heard in our clinicals there was some kind of ratio of drugs given, and they, like, she quickly mentioned that as like a 50-10 or something.
I don't know. I haven't really heard about that. Dr. Starkovich, have you heard about that?
No, for antidepressants or anti-xiolytics.
The Holy Trinity drug that you guys were just talking about.
Oh, like 50 milligrams, 2 milligrams, 10 milligrams?
Is something like that, yes?
That makes sense. That makes sense. Because, you don't want to give a bunch of Haldol. I would imagine that would be the 2. And the the Benadryl would probably be the 50. And the 10 may be the Ativan. That would make sense. I've seen it given. I've been clinical faculty for Concordia University in your amazing program, and I was a behavioral health at Shoal Creek, and I've seen it given. And basically, you make sure that you secure a patient's safety first and foremost, and it's only given in very, very extreme conditions. Very extreme conditions. But Jasper, that's a really good comment. Thank you for providing that insight. And certainly thorough patient teaching, avoidance of adverse effects. And I'll say this today, and I'll probably say it again. I think I said it last week as well. But there are 3 things you always watch for when you give any sort of medication. And this is actually, I think, part of one of your test questions next semester. But you always, if you're going to give a drug, you always assess 3 things. Number 1, did it do what it said it was going to do? You give a blood pressure medication, did the blood pressure drop? Number 2, what are the adverse effects? You give a beta blocker. So a lot of the times when people go on beta blockers, they experience, or they can experience, low blood pressures for sure. And so, if they are hypotensive, Then, of course, it wasn't supposed to do that. It was only supposed to control the blood pressure to a perfusable level. And so, you know, hypo or orthostatic hypotension is not one of the things it was supposed to do. And so then number 3, are there any measures you can take to determine the level of the drug? For instance, the blood pressure, blood pressure obviously is an antihypertensive. If you're giving a medication like, say, Risperidol, you can do a level, you can do a drug level. So the third thing you always check for is if there is an objective way that you can measure the efficacy of that medication in their system. You can do, like I just said, you can do Risperidol level, you can do vancomycin peak and trough, and you can do, let's see, lithium levels can be drawn, Dilantin levels can be drawn. Those are Dilantin is something you be using for seizures, and we'll talk about that extensively next semester for sure. So hopefully we'll bridge these 2 semesters for you to kind of give you a really smooth segue. So, and as far as indications about the central nervous system, sedatives, certainly hypnotics cause sedation, and certainly they're only used for short term. They do affect the serotonin level in the reticular activating system in the brain, and certainly while they're metabolized in the liver and excreted in the urine, we always make sure that our patient has a good liver function. Hepatic function is on the up and up. Let's see, what else can we talk about? Are there any questions about that? Before we dive off head first, not in the shallow water, the deep water, into antidepressants. Oh, thanks, Michelle. What should we know about serotonin syndrome? Okay, so Dr. Starkovich, do you want to answer this, or you want me to?
Sorry, I lost you. You can answer it, because my first thought was you can die.
You can actually die from serotonin. So serotonin, and I forgot to mention this earlier because I had a couple of notes on the major the neurotransmitters. Let's find my notes. So let me find my notes on, because I had a few. Can't believe I didn't. Okay, I forgot to mention this. So rewind. There are basically 5 major neurotransmitters that we will touch on, and certainly next semester as well. There's a neurotransmitter called acetylcholine, and its functions are associated with Alzheimer's and myasthenia gravis. And acetylcholine is one of the major players in not only the development but the progression of these 2 disease processes. Dopamine is one of the neurotransmitters that are associated with Parkinsonism, the inability to use dopamine in the brain. Serotonin is another neurotransmitter, which, bingo, serotonin syndrome, it's associated with mood and depression. And then there's glutamate and GABA, and they're all responsible as far as epileptic disease conditions and also seizures. So having said that, serotonin is a chemical in your body that your body produces that need for nerve cells in the brain to function. However, unfortunately, too much serotonin causes signs and symptoms that can range from mild shivering, diarrhea, to certainly muscle rigidity and seizures and fever. Severe serotonin syndrome can cause death, sudden death, for sure. Certainly it's triggered when you have too much nerve cell activity. It doesn't usually typically go away on its own unless it's a mild case. And sometimes it happens because your patient has taken too many SSRIs. And then a lot of times it can happen because your patient, and this is something you'll learn about next semester as well, St. John wort is one of those drugs that keeps the serotonin circulating through your system. So if you take St. John wort and an SSRI, also develop serotonin syndrome. A lot of times it can be life-threatening, especially if your patient has an irregular heartbeat, fever, shakes, those sorts of things. So basically, it's just when you have too much medication that causes high levels of serotonin to accumulate in your body. Sometimes you can get it in a very short amount of time. Sometimes people have been known to get it if your patient is taking say an SSRI and they forget to take it Monday, they forget to take it Tuesday, and they go Wednesday rolls around and they say, oh, I'll just take 3. So that's the things that you have to talk about to your patient. If your patient comes in and says, oh, I didn't take it yesterday, I should just go ahead and take, or day before, I'll just go ahead and take 2 right now. Well, certainly that's something that you need to call the doctor, the physician for. There's a drug, it's a serotonin 2 agonist that sometimes is used. And a lot of times if people come in as far as overdosing on their SSRI, it's called cyproheptadine. And of course, you know, if you are blessed enough to be an emergency room nurse, then I'm sure these are some of the tools that will be that you'll have at your disposal. Yes, yes, Michelle. Those are also very good questions, which is why, unfortunately, well, the United States uses more SSRIs than everybody put together in the whole wide world, and yes, they can cause suicidal ideations, and yeah, they can. Anyway, the good news are on other news that you'll need to know going forward in this for the content of this class is that unfortunately they take a while to work. If the side effects turn up pretty quickly, then SSRI is probably not going to be the ticket to wellness. Usually, typically, mostly, at least that's what they say, the symptoms are mild and they go away in a couple of weeks. Certainly, you have peak effects once the therapeutic level is experienced. Anyway, sertraline or Zoloft is one of those specific drugs that takes anywhere from 2 to 6 weeks to kick in. So I don't know if that answered your question or not, perhaps. And unfortunately, sometimes they do cause worsening of suicide. One of the things that you always watch out for is antidepressants as far as people are in deep depression or there's a profound depression that when people are experiencing it, they have almost no energy at all. They crawl under the covers and they don't get off the floor, out of bed, and sometimes those are the particular people that you need to watch for suicide ideations, because they start to feel better, and if they're still depressed, then they may have the energy to commit suicide at that point. And that happened to a very I say a neighbor, I said good friend. She actually committed suicide. She was a friend. Her son was a friend of my middle daughter's, and she was profoundly depressed. She wouldn't get out of bed. She finally went to the doctor. Our other neighbor was a physician. He prescribed actually an SSRI, and she started feeling better. And she kept saying she was going to get run over by a train. Well, lo and behold, she decided one day that she was going to drive across town and park her car on the train tracks. So yes, fascinating. I'm a behavioral health nurse by trade. I have been at the bedside of some pretty amazing and or sad situations. So this is something that's, thank you, Michelle, and who answered that question. Ask that question, because it's something we as healthcare providers and certainly nurses are on the front lines of depression treatment and certainly patient care. So I know I got down a rabbit trail on that, so I apologize. There's something called the biogenic theory of depression. It's basically there are certain amines or certain proteins in everyone's system, and a deficiency of these specific amines or protein derivatives, to include norepinephrine, dopamine, and serotonin. There is a deficiency of these, and the reason why we prescribe these antidepressants is they are thought to raise the levels of these biogenic amines. So how do we prescribe these? There's certainly MAOIs, SSRIs, and tricyclic antidepressants. Some of them have varying degrees of side effects. Some are worse than others. For instance, tricyclic antidepressants are sedating and anticholinergic. MAOIs are CNS related and sympathomimetic by nature. The adverse effects of SSRIs are fewer. However, they do cause CNS changes. Of note, MAOIs, you shouldn't. Does anybody know what you shouldn't drink? What sort of juice you shouldn't drink when you take MAOIs? Mm-hmm. Very good. Very good. What about, let's see, anything about tricyclic antidepressants? They have very serious side effects. They can have very serious side effects. What, anything particular? One thing about tricyclic antidepressants is they have a black box warning on suicide thoughts, ideation. Certainly, they can cause them as well. They're only because they work by preventing serotonin at times, and certainly norepinephrine. And so, because they're so profound, they can actually break more than they fix. And they certainly have a black box warning as far as children, adolescents, and children. SSRIs typically work better in adults. I mentioned as far as Zoloft, it usually takes 2 to 6 weeks. Well, actually, all of them do. And if the symptoms become pretty drastic initially, that means that there's something wrong where that particular drug does not fit well to that person's metabolism or lifestyle. MAOI should be avoided in children. certainly because of the potential of drug-to-food interactions. SSRIs certainly can cause serious effects in children as well. Fluoxamine and sertraline have established pediatric dose guidelines for obsessive compulsive disorders. So that is, you might see these two medications given in adolescents and children. And certainly they're dosed by weight, age, and weight. And certainly underlying reasons for depression should be ruled out before antidepressants are started. Certainly people can be depressed for other reasons other than chemical imbalance. You know, maybe there's a serious situation going on at home. Maybe there are other drug-to-drug interactions that could be depressing the central nervous system and maybe causing signs and symptoms of depression. So those are all the things that we need to rule out for sure. Absolute sure. So I've talked a whole lot. Does anybody have any questions?
Somebody asked a question about benzodiazepine overdoses and if we can reverse them with medications. You can use flumazenil for a benzo overdose, and then you also want to support the airway since the major side effect is respiratory depression and decreased levels of consciousness.
Yep. Flumazenil is a benzo antagonist. Absolutely. 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 And you have to remember there's other things that you can reverse. Just remember what's going to happen when it all gets out of their system. They could go back manic, or they could go back into seizures, particularly if the benzo has been given for calming the central nervous system. And like Dr. Starkovich said, always make sure you have emergency equipment available. Always, always, always.
Yeah, because if the patient had a seizure, you're not going to reverse it. Especially, you know, you don't want to risk brain damage or possibly death if it's a grand mal or something like that. So you would just support the airway versus reversal. So it's really important to know what's going on, why they got the medication. You know, and there are other meds we'll talk about later on as well when we talk about pain management for reversal agents also.
A lot of times there's oversedation. There's some literature out there that says vitamin B12 can actually reverse. It's an excellent antidote for hypnotics, although, you know, at a pinch, I'm not sure it would be used for that. So anything like Ativan, Librium, Valium, Xanax, Roperidol, not Roperidol, Rofinol. Certainly it's the flumazenil as well. Activated phenobarbital, which we'll talk about next semester. It's also a CNF depressant. It's given for seizures. Activated charcoal is actually the only thing that really, multiple doses of activated charcoal, for sure. So, any questions? All right, who's going to say a prayer?
Oh, that's a good question, Sabina. Yeah, you always want to taper off one medicine before starting the other for antidepressants, because we never want to stop antidepressants cold turkey. So we always taper off. Sometimes it could be months for the transition. So a couple of weeks at least.
Yeah, for sure. 4 to 6, yeah, for sure. You have to take one down and take the other one up.
Yeah. So it's a very slow process, very slow. And then,
And certainly if you do it too fast, yeah, then you have serotonin syndrome opportunities.
it's not necessarily for our body to recover, but our body is used to it. I guess you could say for our body to recover, I suppose. But you probably don't want to be around that person who's transitioning down. There is something
Yeah.
too called a drug holiday with antidepressants because shockingly there's a side effect of impotence. So if you want to have a fun weekend with your partner or whatever, and you want to be off it for the weekend, I don't know why I keep saying fun, to have some fun, um, then you can do that as well. When I was in middle school,
Yeah,
we
certainly.
had to use fun for the word sex. So I think maybe that's why using fun. Like fun. Anyway,
Well, and certainly there are other benefits like being able to sleep. Certainly, if you have a high stress job and you're off on the weekends, certainly a drug holiday can kind of take the anxiety perhaps down a level as well. So yeah,
yeah,
but that's a good point. A drug holiday is typically taken on the weekend for various and sundry reasons, for sure.
yeah. So just something to note. It's not like a week or a month or anything like that. It's a couple of days, and you need to have your provider's permission first. It's not something that you can just decide on your own. Okay, so it's something that you really have to collaborate with your provider for, whoever's prescribing it.
Absolutely, absolutely. All righty. Does anybody want to offer up a prayer? Anybody want to? Last week's lecture, Millie. Actually, I did it at the beginning of this class, and no, and it didn't save, and so everything that I said last week, I gave a 15-minute synopsis. It was on things like toxic effects of drugs, assessment of
Teratogen.
drugs, challenges, teratogenetic properties of drugs, extrapyramidal effects, which is head tics and movement disorders from drugs. Those are the highlights. Certainly, I mentioned, please challenge yourself with dosage calculations questions, that they will be on every exam that you have in pharmacology. And certainly every exam, most exams you have in nursing school, there'll be a pharm question or two or 12.
I think we give you all the dosages right now, but you should certainly know, like in clinicals and practice, what too high of a dose would be. But
Yeah.
for the
For instance,
test,
morphine.
yeah, we give you the dosages.
Morphine causes sedation. Always do respirations. No ceiling doses. Even you'll be required to look them up in clinical for sure.
Yeah, I would say that's something that you do more in clinical. Towards the end of the semester, when you start giving drugs, you have to know, the nursing implications. What's the indicator that's specific for the patient, not for the drug? What's the dosage range, and is this within the range? Is it an underdose or an overdose? Things like that you're going to do in clinical. So, but for this class, definitely, like Dr. K said, know the main side effects, especially of the classes, and if there's anything that's a little weird or wonky for a specific medication, know that, because it'll probably be on the test if it's weird, maybe.
All righty, time to pray. Unless there's no further questions. All right. Dear God, thank you for this opportunity to gather, to share information, to for Dr. Starkovich and I to represent you to our students so they go forward and represent you to the world. We pray over this time together. We pray that this has been an effective use of their time, and that all of the information that we've been able to bring to this class not only provides clarity for the exams, but certainly continues to build a solid foundation on which to develop their professional nursing practice. We pray over each one of our classmates. We pray over our college. We thank God for a wonderful program and certainly the opportunity to become a professional nurse. We pray for all of our families, all of our friends, all of our communities, particularly during these unsettling times. The experiences that we're having right now are some that no one has ever experienced before us, and so we take these opportunities to go forward with an expanded knowledge base, certainly an open heart and an open spirit to all of those that God will graciously and lovingly put in our paths to provide care, guidance, and certainly spirit for. And I pray these things in the name of your precious Son, Jesus Christ. And I close by thanking all of you for your time, and promise that Dr. Starkovich and I certainly appreciate your time. It's not only valuable, but it's a gift. And so I hope each and every one of you have a very blessed evening, a very blessed week. And Dr. Starkovich and I will be posting the exam review, and you'll find in our exam reviews they're more than just a blueprint. They're kind of guidance, study guidance as well. So anywho, unless anybody has any questions, we are done for this evening.
Bye. Have
Indeed.
a good night.
Toodles, everyone. Ta-ta for now, as Tigger would say.